Hello, everyone, and welcome to this podcast on neuromonitoring. My name is Massimiliano Meineri. I work at the Herzzentrum Leipzig in Leipzig, Germany, and I'm also the annual meeting chair for the EACTA IC. And I'm very pleased today to spend the next 10 minutes talking about neuromonitoring in cardiac surgery and provide an overview of current evidence and suggestions from current guidelines. Neurological complications after cardiac surgery are not uncommon. If we look at old studies where they've scanned with MRI patients who underwent cardiac surgery without being selected before, half of the patient had some sort of changes. And in fact, it's been reported that neurological changes after cardiac surgery occur in almost half of the patient, and they range from delirium to cognitive dysfunction to full-blown stroke. Neurological complications are often, not only, but a result of ischemia, which is either global ischemia due to not enough perfusion to the brain, or focal ischemia due to embolic load, so emboli that have been shot to the brain. How can we provide the best possible care to our brain during cardiac surgery, and what instruments do we have? We have the opportunity to basically use 3 different methods to monitor brain function, and they are not new, but they're still valid, and we're gonna go over the pros and cons and the pitfalls of each of these methods, starting from electroencephalogram. Electroencephalogram is the monitoring of electrical activity of the brain. This is something that we use on a regular basis at our center, and I'm sure many of you use on a regular basis. What do we get from electroencephalogram? So this is not a complete electroencephalogram. That's what the neurologists do with 48 channels, but this is usually on just a few channels on the frontal lobe. We get a signal that's a EEG signal, and then we get a processed ECG. We process the ECG signal to get a number. The ECG signal, we see that depending on different conditions, it changes, and it changes with how deep the anesthetic is, and it also changes with how much the brain function is. So we can use this signal and process it to make it into a number to see if the patient is awake. Where we have number 0, there's no electrical activity and the patient is deep in a deep coma, and 100 where the patient is fully awake. We want to keep this number between 40 and 60, and that's specifically very important in cardiac surgery because the incidence of awareness intraoperatively is higher than for non-cardiac surgery. However, in cardiac surgery, it's also useful to look at the EEG signal alone itself, so the signal, unprocessed signal, to look how it changes with the change in temperature. And this is very useful, for example, when we do deep hypothermic circ arrest, to make sure that the electrical activity of the brain is shut off so that we have a minimum oxygen consumption in this very critical phase of an operation that require the circulation to be stopped in order to often work on the arch or the ascending aorta. What are the suggestions from the use of EEG from the German Society of Anesthesia? The suggestion is that we should use EEG, processed EEG, when we do a TIVA, which is a very common scenario in cardiac surgery, when we do deep hypothermic circ arrest to look at the burst suppression, and also in patients with history of awareness and in patients with decreased cardiac function, so where the ejection fraction is less than 30. Why? Because if we actually look at the depth of anesthesia, we can minimize the amount of drugs that we give and minimize the hemodynamic effect of these drugs. The combined guidelines from EACTA-IC, EACTS, and the Society of Perfusion, they were published last year on the cardiopulmonary bypass. They also mention neuromonitoring, and we're talking about EEG. They say that it's reasonable to use it, although the evidence that the use of EEG has an impact of mortality is not there, but definitely prevents awareness in patients who are at risk of awareness, who had awareness in the past. Another modality to monitor the brain is to monitor the oxygen saturation in the brain. And how do we do that? We do it with near-infrared spectroscopy. Near-infrared spectroscopy uses electrodes, special optodes with a light source and two detectors. A detector that detects what is reflected from the surface of the skull, so from the skin and the skull, and a second detector that detects what's coming from the surface of the brain itself. So we place these two optodes in the on the stern, and what we get is a saturation. The saturation that we get from NIRS is not the same as what we get from a pulse oximeter. What reflects is regional oxygen saturation. And regional oxygen saturation is not only arterial saturation or arterial oxygen contents, but represent from 70% the venous saturation or the venous oxygen content, 5% the capillary oxygen content, and only 25% the arterial oxygen content. What it's important to know, and what's a big advantage of NIRS, is that we don't need pulsatility to use NIRS. We can then use it during cardiopulmonary bypass, and we always have a measurement. There's been now a wide body of literature on the use of NIRS, and we've learned that there's many algorithms that show that once we have set a baseline of NIRS and during the operation we see a change in more than 15% of the baseline value, then we should intervene. If we intervene to increase the saturation by means of providing more oxygen or more blood flow or more hemoglobin to the brain, then there is a benefit in postoperative outcomes. What's also been seen is that the patients who come to the operating room with extreme low NIRS values, less than 50%, they have a worse outcome. And also, if we give oxygen and this NIRS value doesn't come up, then is also a sign that this is definitely it's a worse outcome. So NIRS gives us the possibility of monitoring the brain throughout the operation and to intervene to achieve a change. The German Society of Anesthesia actually suggests to use NIRS always when we do surgery on the aortic arch. when we do operate on adults with congenital heart disease, when we do carotid endarterectomy in a patient under general anesthesia, in patients with a previous history of stroke, who have still neurological deficits, and in patients during heart and lung transplantation, and in patients with untreated hypertension. We've done also a small analysis, a retrospective analysis in our center to look at a period of time where we used NIRS for everybody. And we looked at if having used NIRS on everybody allow us to make decisions or change our treatment of the patient only based on the NIRS value, or in other words, would have we done something different if we didn't have NIRS in these patients? And the answer is that we would have done these changes also without NIRS. The EACTA-IC ACTS cardiopulmonary bypass guidelines, they also suggest the use of NIRS, and they add that there's more evidence that we also should use it all the time when we use ECMO. The last point for this talk is on transcranial Doppler, and I will be very short on that. I have little experience based on some research we've done, but we don't use it on a regular basis. And generally speaking, this is still the trend, and also the latest cardiopulmonary bypass guidelines, they state that because this technique is finicky, requires special equipment, getting a good windows through the brain is not easy, although has a big potential, but it's still not come to the point, despite it's been around for a very long time, that we should use it on a regular basis and suggest its use in guidelines. With that, I'm done with this podcast. I hope I trigger some interest, and I could explain some concept that may not have been clear before. I'm always reachable on my email, and I hope to meet you in person and chat more about these topics. Thank you very much, and have a nice day.